So in the previous video, I alluded to that there's actually about 30 known consultation models out there. And in this video, we're going to take a look at what are some of the common trends across them and why it's important that we should actually learn about these. You're probably no stranger to models, and models are drilled in us from our undergraduate days. Reflective models, models of teaching, models of learning. There's a model for everything. And in this video, we're going to take a look at what are some of the common trends of models and why we should learn about consultation models in the first place. So what is a model? And we've already established that they come in a variety of shapes and sizes, and we've been exposed to them since our undergraduate degrees or earlier. Essentially, a model is a hypothetical way to describe a complex process. And the key word there is hypothetical. It's not in real life, but it allows us to describe something that's happening in real life and place a pictorial or figure representation of it, something like a flowchart that many of the models have. But they come in many shapes, sizes, and styles. Some of these consultation models that you're going to see are really quite short and only have 3 or 4 points. Whereas as we move through the presentation, you'll quickly learn that some of them have about 72 points. The key point is that these are hypothetical. They don't necessarily depict how your consultation is actually going to happen. It's also important to remember about models that not one size fits all. We can see this in reflective models, that some of us don't like Gibbs, some of us like Kolb, or some of us like Borton's model. It's exactly the same with consultation models. Calgary-Cambridge isn't for everybody, and likewise Neighbour isn't for everybody. And what we often end up doing is making these models fit using a variety of methods in our clinical practice, or whatever practice we do using a model. The important thing to realise when you're using these models in clinical practice is they're not based in the real world. It's a description of a complex process, and that process can change, and we're all aware that our consultations sometimes don't flow in a logical order. But what these models do enable us to do is have a better understanding of the real world systems by placing it into a flow diagram that we can then use and try to apply to our clinical practices. So what's the point about learning about models or consultation models? Well, actually, subconsciously, we make a model for everything that we do. And typically what you'll have in your head is a large flowchart of yes/no answers, which leads you to a decision. And this is based on the experiences that you have. But what we can do by studying models is we can actually make up our own. And what you'll find as you move through this presentation is that you might be able to select bits from each model to make your own. And this is through experiences practicing and the clinical encounters that you have. But consultation models, what they help us to do is understand the patient's perspective. And what we're seeing increasingly in what patients want is they want individualized care and they want shared decision making. And if we apply a model to our consultations, it can force us to not be so task orientated and actually consider the patient's feelings, values, or beliefs. And also, by doing this, it actually means that we get better concordance. We're more likely to get the patient to agree to the management plan and take ownership of their own health, care, or social needs. Ultimately, consultation models make us thorough and safer, and there's plenty of evidence to suggest this as well. So what we can do is say that models allow us to have a potentially structured approach to our consultation, gain experience of people or the research that's been used to found them, and it forces us to consider the patient's expectations, ideals, or beliefs. If we look at models more generally, not just consultation models, but teaching, learning, reflective, or really any models, we can find that they all share 3 key aspects, and this is common across all models. The first is that they require an information input. There is always information being put into a model in order to arrive at a conclusion or decision. For example, in the context of clinical examination models or consultation models, we can see that data gathering would be the information input in the Calgary-Cambridge model. The second thing that all models share is the information processor. In the context of clinical examination models or consultation models, that's the doctor, or in our case, that's us. And we're considering the problem, for example, in the Brian et al. Model. Finally, we get an output of results. And this is where we divulge our diagnosis, our management plan, and share an action plan or treatment plan with the patient. This can be safety netting or housekeeping. And what you'll see in each of these models is that they have all of these aspects ingrained into them. But they have different orientations, and by that we mean that they can be orientated towards the patient, towards the practitioner, or towards completing a task. And what you'll notice about these models in particular as you move through the presentation is there is lots and lots of overlap. A lot of them can be likened to each other, and essentially what we see as the models grow over time, coming up to the Calgary-Cambridge model, we see them getting more and more complex, taking into account more and more communication needs, both verbal and non-verbal. And this is what's happened over the time, is that they've become less orientated towards the doctor or the practitioner and more orientated towards the patient's needs. In the presentation now, we're going to move on to actually examining some of these consultation models. And I'm going to present to you 8 models, starting at 1975 and working all the way to 2013 with Calgary-Cambridge, which many of you are probably familiar with. In each of these sections, I've included references to the original articles and also some pros and cons for each of these that you might want to reflect on for your assignments. Finally, we're going to finish up with some trends that are common to them all, and then I'm going to finish off with a what all does this mean for your assignment and how can you integrate some of this information moving forward.